Hi, my name is Rebecca Metcalf, and I'm excited to be sharing this work with you today on how to make clinical trials more meaningful for everyday decision makers and for patients. This is work that I led as part of my PhD dissertation at the University of British Columbia, and it was supported by an excellent team of health economists, patient partners, and statisticians, as well as clinicians. So I'm really happy to be presenting all of this work done by me and this excellent team with you today. So just a quick overview of what I'm going to be talking about. I'm going to be talking about composite outcomes, what they are, some problems with composite outcomes, the proposed patient-oriented solution that we devised, what happened when we did it, so what did we do, and then what did we find? So composite endpoints, just in case you're not familiar with them, generally when we do a clinical trial, we want to study the most important outcome. And often this is something like death. But if we focus just on one outcome, we might miss other important outcomes. So for instance, if we focus just on death, we might miss heart attacks. And also some of these major outcomes often are quite rare. So they might not actually happen during our study window. So sometimes we also include sort of more common outcomes that we're more likely to actually see within the study timeframe. So something like severe high blood pressure. But when we have 3 different outcomes and we do 3 different analyses, that increases our type 2 error, which is the likelihood that we will find an effect or declare that a treatment is effective when it actually isn't. So instead we combine them. And this is what we call a composite outcome. And in this sort of setting, having any one outcome counts as an event. So if I have severe high blood pressure, that counts as an event. If I have a death, that counts as an event. If I have all 3, that counts as an event. So you might be sort of starting to twig onto some of the problems that composite endpoints propose. But there are definitely some advantages to composite endpoints. So one of the big ones is that they increase statistical efficiency or power. So what that means is that I actually need to recruit fewer patients into my trials so I can do trials in a less costly and more efficient manner. They also, it's not just about efficiency, it's also about sort of covering the breadth of a disease. So different diseases may manifest or present in different ways. So using multiple outcomes might allow us to sort of capture the different ways that a disease or a condition might present. But there are definitely some problems. So one of the big problems here is that these different outcomes aren't equally important. For instance, we probably care more about death than we care about heart attacks, and we probably care about heart attacks more than we care about severe high blood pressure. But in a composite endpoint, they're all treated the same. Another problem is that we don't see these events happening at the same rate. And actually, as I mentioned earlier, that's one of the reasons we make a composite endpoint, because we want to make sure that we're going to see some of the outcomes during our study window. But what that means is that often we'll see a lot of severe high blood pressure and not very many of the other outcomes that might be more important to us, sort of like death or heart attacks. And when we put that together, what we really see is that results in clinical trials are often driven by the least important outcome. And what that means is that although we want to be measuring what is the impact of this treatment or intervention on death or heart attacks, we often are really measuring what is the effect of this treatment on severe high blood pressure, which might not be what we're the most interested in. There's an additional problem with composite endpoints. And that is that treatments can affect different outcomes differently. So although these are all different ways that different things that might happen in a given condition, there might be different underlying disease processes that are causing these different outcomes, and treatments might affect each of those processes differently. So if you look at this graph that I've put together, this isn't real data, just sort of to show the point. You can see that treatment A and treatment B have differences in the number of heart attacks, deaths, and high blood pressure, but actually there's the same number of total events. So if we looked at this using a composite endpoint, we would see that the 2 treatments are the same, even though we can see when we look at each outcome separately that there are significant differences. Despite these concerns, composite endpoints are really common in clinical trials. So I think almost every clinical trial that you'll see published today, the big trials that are getting lots of attention, use composite endpoints. And that results in statements like this. And this is a statement from a trial published in The Lancet. And what they found was, in this large prospective blinded international clinical trial, our intervention, together with lifestyle recommendations, substantially reduces the risk of diabetes or death by 60%. Well, which is it? If I'm a patient or I'm a clinician, I want to know. There's a big difference between diabetes and death. But this kind of approach doesn't allow us to tell which is being affected by the intervention. So what's the real problem here? The real problem is ultimately that every year we spend millions of dollars and we use thousands of hours of patient time to conduct trials that we then struggle to interpret in the clinical context, and we struggle to apply to treatment decisions. And really, that's why we do this research, to help us be able to make better clinical decisions and to understand what our options are and to understand what treatment might be best for any given patient. But if our clinical trials aren't giving us outcomes that are understandable, it's really hard to understand what to do with that data in a clinical situation, or if I'm a patient trying to make a decision about what treatment is best for me. But there's got to be a solution, and I'm sure there are many solutions to this, but this is the solution that we are proposing, which is to add weights to the analysis that reflect the importance of each composite component, or of each outcome that's included in that composite endpoint. So for example, in a traditional composite endpoint, we treat each of these outcomes as though they're the same. Instead, what we're proposing is that we weight these outcomes so that they reflect the importance of the different outcomes. So this would be similar to what you do in a course where your final exam is worth a lot more than a pop quiz or a midterm assignment. But this raises another question, which is whose weights and whose outcomes do we use? And here I'm going to make an argument that we should be using patients' weights and patient outcomes. And the reason is that we know that patients prioritize different outcomes than clinicians and researchers. For instance, patients might prioritize quality of life outcomes more than clinicians would. We also know that patients are the ones who are most impacted by trial results because they experience both the interventions and the outcomes. So there's sort of an ethical or moral imperative here that patients should be involved in understanding how we evaluate a treatment and which treatment is best for them, because they're the ones who are going to have to live with that treatment. So our ultimate aim here was to look at how can we integrate patient preferences into clinical trial analyses to make them easier to understand and easier to use in clinical practice and in decision-making about patient care. So what did we do? Well, we looked at the CHIPS trial, which was a large trial that was published in the New England Journal of Medicine, looking at high blood pressure and pregnancy. This was an international open pragmatic randomized control trial, which is essentially the most close to real life that we can get in a clinical trial. And it had about 1,000 individuals, whereas previous trials looking at high blood pressure and pregnancy only had about 300 people. So we're better able to detect a significant treatment effect in a larger group of people like this. And the CHIPS trial compared two treatment approaches: tight control, which is really an intervene now approach, and less tight control, which is more of a wait and see approach, where you don't intervene unless a person develops really severe high blood pressure. And the CHIPS trial used a composite outcome. They looked at infant death and high level of neonatal care. And we can see that there's sort of a big difference in importance here between having an infant die and having an infant need to be in the NICU for several days. And they didn't find a difference on the composite outcome. They did find some differences in their secondary outcomes. So they found that tight control was significantly better for severe high blood pressure. So fewer people who received tight control developed severe high blood pressure. And although not statistically significant, they found that there was a clinically significant treatment effect where less tight control was better for reducing the risk of a baby being born smaller than expected. But the CHIPS trial really changed treatment in hypertension and pregnancy. And so current clinical guidelines changed to recommend tight control of pregnancy hypertension and that care providers consider patient preferences. But right now, there is no well, I guess until now, there was no real way for patients and care providers to integrate their preferences with the CHIPS trial data. So if we look at this slide again, what am I supposed to do with this? There's no difference on these really important outcomes. And then there's differences on other secondary outcomes, but in opposite directions. So we looked to see what we could do to make these results easier to use in clinical practice. So first, we talked to patients to find out what they prioritize when making this health decision. Then we used a survey, a preference elicitation survey, to quantify the importance of each of the outcomes that we heard from patients were important. And then we integrated those results into the trial analysis using a patient-oriented composite and a patient-oriented weights. So when we spoke to patients, what we heard was that they prioritized avoiding 7 different outcomes and interventions. And these are those 7 interventions and outcomes. So severe high blood pressure, preeclampsia, a baby being born before 34 weeks, baby being born smaller than expected, taking blood pressure medication, receiving a blood transfusion, and having a cesarean delivery. And when we did our survey to understand how important each of these outcomes were, we ended up finding 3 different preference profiles, so groups of people who shared common preferences. The first group and the largest group were people with an unclear priority or no clear priority. The second largest group were people who wanted to avoid early delivery, and the smallest group were people who wanted to avoid taking medication. And you can see here are the weights that they assigned. So in the profile 1, no clear priority, it's all sort of the same. In profile 2, we can see that most of the weight is looking at avoiding early delivery and severe high blood pressure. And in profile 3, it's really focused on avoiding taking medication. And this is just showing the same thing in a different version. So what did we do with that? Well, as I said, we integrated those results into our trial analysis. And we did that in this way. So I'm going to walk you through our hypothetical participant. So for each participant, we looked at each of the events that we were measuring. So this was all 7 events, but I'm just going to show you 3 here for simplicity. And we looked at, did the event occur? Yes or no? And if it occurred, we gave it a value of 1. And if it didn't occur, we gave it a value of 0. Then we looked at how important is the outcome. And here you can see these are just the weights from before. And we simply multiplied through and then summed across. And that was what we called a weighted outcome score. And we did this for each trial arm and then compared between the two trial arms. So here are our results. You can see here that what we found that, like the CHIPS trial, there was no difference when we looked at equal weights or looked at people who had no clear priority. However, when we looked at the people who wanted to avoid early delivery, tight control was better for them. And when we looked at people who wanted to minimize medication, less tight control was better for them. We then wanted to see, for those who wanted to avoid taking medication, how much would their preferences need to shift in order for tight control, the recommended treatment, to be the preferred treatment for them. And what we found was that for people who want to avoid taking medication, as long as avoiding medication makes up 2/5 of the decision or more, less tight control is the better decision. But if it's looking like medication is sort of less than half, maybe 1/3 of the decision, then tight control becomes the better choice for them. And really, at the end of the day, what this is emphasizing is that which treatment approach is best for any given patient depends on which outcomes they prioritize and to what degree. So some of the strengths of this work: this is the first study in pregnancy to integrate patient value weights into individual level trial data. We used both patient weights and a patient-oriented composite. So our composite was composed of the items that the patients we spoke to identified as being important. And then we weighted it by how important each patient said those different outcomes were to them. This addresses issues with traditional composite endpoints and helps us understand how these trial results can be applied in clinical practice. This is a relatively simple statistical analysis, and it can be expanded to other robust parametric approaches. Some of the limitations, it's not really clear what this means for trial design and power if we're looking at how many people should we recruit? This kind of undermines the efficiency gained from using a composite endpoint. So it might be best used as a sensitivity analysis. We did the study post hoc, so after the CHIPS trial was done, but that's how the CHIPS trial evidence would be used in clinical practice. And we didn't use the values of the women in the trial. And in terms of future next steps, I really think that it's important that we stop treating composite endpoints as though they're value neutral. They aren't. And whether or not we weight our composite components really changes how we interpret our results. And we should consider using this in future trials. Thank you.